The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Kashlak Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Paul, it's time to just start the show. Welcome back to the Curbsiders.
If you could just narrate the rest of it, that would be great. Just tell us exactly how we're doing. That's perfect.
So, welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend, Dr. Paul Delsa Williams. Paul, how are you doing?
Hi, I'm great, Matt. Thank you for asking. How are you?
It's very late at night. We've recorded several nights in a row at this point, so we will make this quick, and also we will make this quick because we have a fantastic episode talking about long COVID with our guest, Dr. Monica Verduzco-Gutierrez. And, before we tell you about her and introduce our co-host for this episode, Paul, would you remind the audience, what is it that we do on the Curbsiders?
Sure. Happy to, as always, Matt. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. We should also mention, maybe you're leaving this for me, that we are joined by the amazing Dr. Avital O'Glasser, our chief of perioperative medicine at Kashlak Hospital, who helped coordinate and produce this episode, and whom I'm going to turn the mic over to tell us a little bit about what we talked about before we get into it.
Well, it was wonderful to be back recording with you all tonight and agree. We had a fantastic expert on a topic that really we didn't even know about 2 years ago. So hot off the press, discussed the latest and highest yield information covering multiple facets of long COVID, including potential pathophysiology, illness scripts, diagnoses, cardiopulmonary, neurocognitive elements. We're also diving into the component of the patient voice in this brand new diagnosis.
Yeah, and a lot of practical tips for you in the primary care office, seeing these people, especially if you don't have a big referral center in your area. So let me tell you about our guest, Dr. Monica Verduzco-Gutierrez. She is an accomplished academic, physiatrist, and professor and chair of the Department of Rehabilitation Medicine at the Long School of Medicine at UT Health in San Antonio, Texas. Dr. Gutierrez is a passionate advocate for physiatry and underrepresented groups in medicine via social media channels. She is the social media editor of the American Journal of Physical Medicine and Rehabilitation. Inspired by her upbringing in the Rio Grande Valley, she is dedicated to giving back to her community by mentoring students, trainees, and young faculty and providing top-level clinical care for the underserved. In 2019, she received the Top 25 Women in Healthcare Award from the National Diversity Council and Healthcare Diversity Council. She is currently directing a COVID-19 recovery clinic, the first in South Texas, which aligns with her mission to increase access to interdisciplinary care, optimize function, and improve quality of life for long COVID. A reminder that this and most episodes will be available for free CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. So without further ado, let's get on to our interview with Dr. Monica Verduzco-Gutierrez. Well, Monica, we've been chatting off air for a little while now, and I'm very excited for the audience to meet you too. So can you give them a one-liner about yourself, and then also tell them about a hobby or interest you have outside of medicine?
Okay. My name's Monica Verduzco-Gutierrez. I am from Texas, born, raised, and I am a specialist in physical medicine and rehabilitation with also a subspecialty in brain injury medicine, and also right now taking care of many patients who have post-acute sequela of COVID. And I am the chair of rehab medicine here at UT Health San Antonio. And the thing outside of medicine, it's two interesting things. Probably everyone knows I'm a runner and I really like running, and I do that and post about that a lot. But the other thing that I really like is bargain shopping, and including consignment and thrift type shopping.
Oh, fantastic. That is fantastic. Tell us about a recent great find. What's something you're recently proud of that you found in a consignment or thrift store? I always enjoy hearing about that.
Okay, I recently found a Hugo Boss dress, and it was like $10.
Fantastic.
That's so
Thank
cool.
you.
Congratulations.
I think there's I think there's some TED Talk. I don't know if anyone else has heard about this one, but it was like a TED Talk about how because fast fashion supposedly not great for the environment. And they talk about like some of the more expensive, like well-made stuff just like lasts a very long time. So maybe that Hugo Boss dress, it was expensive at one point, but it's still lasting. Now it's $10. Great find. Very excited for you.
Thank you.
We're saving the planet. You look good. All of it's great.
Exactly.
So my usual question is for a book recommendation, but I'm happy to expand things because that makes people panic so much. So I'm willing to take a book, movie, TV show, album you've listened to, any piece of culture that has been a distraction to you lately, because I certainly would love to quiet my brain. So any recommendation I will take.
So I will also tell you my most recent books that I've been reading have been based on ones. I go on runs, and they sometimes have those little free book boxes, and I'll run to the free book box and see what they have to offer there, and then run back home with it. And that's kind of the book that I'm reading right now. It's a historical nonfiction about the time before World War II when Hitler was coming into power. It's by Eric Larson.
And how much distance between the free book box and home? Like, I'm just wondering how.
It was about 2.5 miles,
okay.
actually.
That's a hike for some historical nonfiction. Yeah, you may not remember this. I think you gave me running advice on Twitter because I mentioned complaining about my IT band. And you're like, you need to strengthen your glutes, stat. And I was like, oh, okay. So like, I was actually very grateful for it because
Yes, exactly. That's the treatment. Yeah, that was
Paul,
me.
And Paul, I believe that the update was that hip was getting better. Is that correct?
100% absolutely true. And I ran the marathon shortly thereafter.
Yeah, didn't you just run the Philadelphia Marathon?
Mm-hmm. Yeah, a couple of weeks ago.
Congrats. How did it go?
I saw that on Twitter.
Thank you. Well, we won't make this. We'll make it a little bit about me. No, that was my first and possibly only marathon, but it went as well as I would have hoped. I made my target time. I finished, and those were the two things I was shooting for. So it was good. Thank you.
Congrats.
We're also proud of you, Paul.
Yes, thank you.
And with strength and glutes.
Yes. Yep.
Yeah. Your glutes are looking better than ever, Paul.
Thanks.
Actually,
I appreciate that. I was hoping you'd notice.
I feel like the next Curbsiders clinical exam series is going to be all about the glutes.
That's it.
There's going to be so much to talk about.
We're due.
It's the biggest muscle in the body.
Avi, did you want to ask anything before we get on to...
I always like the question about tell us about some meaningful advice or feedback that you've received during your professional journey.
Probably the most meaningful advice that I've had is to just go for it. And I kind of feel this is for people who have imposter syndrome, or especially women in medicine, where they say women are not going to go for a job when they don't meet 100% of the criteria, whereas men will go for a job when they meet only 60% of the criteria. And I think I've even seen that in myself, and that probably caused me to not be promoted because I didn't go for it when I probably should have gone for it. And there was no harm in trying to go for it anyway. So what's that? A year of delay, a year of less pay, and even for the job that I'm in now. So what is it going to hurt to go for the job? What's the worst thing that's going to happen? You're not going to lose your current job if you don't get this other job. And, it all worked out. So.
Fantastic advice.
Well, thanks for sharing that.
Yes.
Before we get on to the main show, Avi, did you have a pick of the week? Since you're not on air as often, I figured I don't know if you have one saved up. No.
Do I have anything saved up? I'm going to go with something very current. I am almost finished reading 400 Souls, which is an anthology compiled by Abrams Kendi and Keisha Blaine. It's actually, I will hold it up for those on the recording. It is, I've personally made a lot of effort. I've been very intentional about more diversity, equity, and inclusion reading in the last 2 years, and this is my current read along that very important theme. So it's the 400 Souls it pulls from the fact that there has been slavery in this country since 1619 for 400 years, and it's an incredible anthology of themes in a chronological order across those 400 years, and with really just powerful tie-ins to current state of racism and the challenges that Black Americans continue to face in 2021. So highly recommend it.
I think I like the point you made about like trying to be more inclusive, because if you're not careful, like you might just end up picking books like maybe it's just a product of like who's recommending the books to you, but it's like it's a lot of books written by white men out there for me. So I'm like looking, I'm like, oh yeah, like the last 5 books I've read have all been written by white men. I should probably try to be more intentional about this too. It's a good point.
Same about the ones in the free little book corner.
We know that my sub pick of the week is just curate your reading list. I think Twitter has been fantastic for that, and we will provide the Twitter link for our guest Twitter account in the show notes. I know local bookstores, local Black-owned bookstores have fantastic Instagram accounts and recommendations for re-releases or new releases. Powell's, which is in Portland with me, has really well-curated minority author lists. And if I'm looking for a new read, I definitely go to them first.
Walk through like several city blocks worth of books in Powell's. Paul, did you have a pick of the week before we get on to the main topic?
Nothing burning this time around. I mean, I could always bring up something, but I think we have enough meat in this episode that we should probably just move on.
Okay. Hey, listeners, I'm so excited to tell you about our sponsor tonight, Blue Land. My wife and I have been geeking out over their cleaning products for over a month now. We were so excited to receive their Clean Essentials Kit. You know, because Blue Land solves a big problem for this planet, one that I'm worried about, and I know a lot of us in medicine are worried about. It's the fact that plastic is basically destroying the oceans and just everywhere, including probably getting incorporated into our bodies. And, you know, an estimated 5 billion plastic hand soap and cleaning bottles are thrown away each year. But Blue Land's revolutionary refill cleaning system is going to help get us out of this mess. Because a cleaner planet starts today by eliminating plastic waste. You buy a bottle once and you refill it forever, and their products are beautiful and easy to use. You just fill a bottle with warm water, pop in one of the hand soap or spray cleaner tablets, and within minutes you have a powerful cleaning product with incredible scents like agave and lavender eucalyptus. So please do yourself a favor and check out Blue Land, because right now you can get 20% off your first order when you go to blueland.com/curb. That's 20% off your first order of any Blue Land products at blueland.com/curb. One more time, blueland.com/curb. Our sponsor today is the American College of Physicians. And guess what, everyone? It's time to start thinking about the Internal Medicine Meeting 2022 in Chicago, Illinois. It's happening from April 28th to 30th, and we're going to be there live in person. I would love to see you. Come up and give me a hug. Actually, give Paul a hug, because, you know, he secretly loves that sort of thing, no matter how much he tells you he doesn't. And we are so excited to get back there in person. As we've said many times on the show, the biggest dilemma for us about going to the ACP conference is there are so many great sessions that it is hard for us, even with a team, to get to all of them and figure out just what pearls we should put on air for y'all, because it is jam-packed. You got to be there. You know, I recommend you come and hang out, but if you can't be there, ACP does have virtual access available for select live stream and recorded sessions and CME and mock, so check that out too. For early bird discount, make sure you register before January 31st, 2022, and use the code IM22CURB. That's IM22CURB. So go to annualmeeting.acponline.org and register today to get the best pricing and bonus content. So why don't we get to the case, Avi?
All right. So we have 2 cases from Kashlak Memorial today that we hope will lead us into a really robust discussion about this emerging clinical challenge. Out of respect for our patients and friends and colleagues who may be experiencing long COVID, I tried not to get too silly with our patient names today, but I'll start with case 1. Patient Sarah S. Covey is a 45-year-old woman who was diagnosed with COVID almost a year ago exactly, December 2020. And what she says is that her symptoms were initially mild, 3 days of low-grade fever, some nasal congestion, mild cough without dyspnea. She never needed to go to the ER or urgent care or any other higher level of care. And she felt that she recovered at home within a week and stayed home until she finished her isolation. But by mid-January, so about 11 months ago, she developed a recurrent cough and mild dyspnea. Her primary care clinician did a chest x-ray that was normal. And then she's continued to have dyspnea, sort of an activity-induced cough, and really significant fatigue that's affected her ability to exercise as well as be active at work. And then by March, she felt that she just had no, and she's going to do air quotes, get up and go, spending hours a day on the couch or in bed, and starting to feel lightheaded and with palpitations whenever she stood up. She comes to you saying she saw a news article about the opening of a long COVID clinic at Kashlak Memorial, and she's interested in seeing if she's eligible for a referral. So let's do this. Let's start off with taking a big step back. What is long COVID? And we're using the terminology long COVID, but is this even the right terminology to be starting off with?
So there's lots of terminology. So that's a great question. So long COVID, this is going to be the syndrome that's characterized by varied persistent symptoms that patients have after having an initial COVID infection. I think there is, just depending on what site you go to, what it's called. So the CDC also has, post-COVID conditions, and they say these are new symptoms that can happen. And it's, they say 4 weeks or more after having COVID. So if you had COVID and then you're still having symptoms 4 weeks later, then that's going to be a post-COVID condition. And then we have a formal name that the NIH came with, which is the PASC, or the post-acute sequela of SARS-CoV-2, PASC. And then this was what they announced in February 2021, saying, okay, these are sequelae that are going to occur after you've been infected. And then on top of these two major organizations, now we've had the World Health Organization that's come out and also has their own definition. And they're saying post-COVID conditions can occur in people who had COVID or probably had COVID, because we know at some points testing wasn't great and people weren't even able to get positive tests at the beginning, if you think March, 2020. And usually symptoms occur within 3 months. And so it can be up to 3 months that they're saying this occurs, and they last at least 2 months. So a little bit different with timing compared to some of the other definitions. And probably another, kind of term you might hear is long hauler. I'm not kind of a big fan of that term. I know a lot of it was some of the patients came up with the term being a COVID-19 survivor who has these lingering effects. But some of the patients dealing with long COVID are not fans of the term. So I just usually use long COVID or PASC or post-COVID condition to describe patients that I have.
Well, that's super helpful. And I didn't even realize that there were that many sets of terminology for it and so many, so it seems like overlapping but different definitions.
This would explain too why when I was trying to read, there was, it seemed like varying, like sometimes it would say you have to have at least 2 months of symptoms. Maybe earlier on they were saying they have to have 3 or more weeks of symptoms. Does it matter that much? Like if someone's got a month or 2 of symptoms after a COVID infection, is it okay for us to sort of think that they may be in one of these, long COVID, post-acute sequelae? What do you think? For
sure. Okay. Yeah, I think, potato, 2 weeks, 4 weeks, 27 days, 35 days.
Okay.
It's just, again, focusing it on the person and what are their symptoms, validating their symptoms and figuring out how we can help them.
I guess I just wonder how, from a science standpoint, we're defining our terms. It seems like if you have such a large swath of the population affected by something, and then you have this huge array of symptoms and things that can happen after this large swath has been infected, how do you decide what is attributable to COVID? What is attributable to something else? Like, I think it's from and this might lead us down the pathophysiology route, but I guess how are we determining what constitutes long COVID versus what is just illness that people get from living long enough, or, because I feel like it's kind of hard to tease things out when so many people have been affected at this point. I don't know how everything is directly attributable to COVID. So I feel like that has to muddy the waters. I don't even know if there was a question in there.
Yes.
Perfect. Nailed it.
Right. Yes. I think they're trying to say, were you sick related to COVID and it continues going on? Or did you have COVID and something occurred within the first 2 months of having COVID, and then it may be related to COVID?
Perfect.
But I'm still with part of these definitions are, and it's not related to something else. It's not explained by an alternative diagnosis. There's people that want to come in and say, it's long COVID. And I have to say, oh, you're saying you have stool changes, fatigue, your bowels are changing. You still need to have your regular care. And you've never had a colonoscopy. What if you have colon cancer and you're saying you have long COVID? We have to be able to also say it's not an alternative diagnosis.
So I had a patient at Kashlak a couple of weeks ago who had asymptomatic or mildly symptomatic breakthrough COVID and sees primary care 2 months later and says, I have a cough. They stop lisinopril, the cough goes away. I shouldn't be worried that he has residual symptoms from his COVID because there was a really readily available alternative explanation for a persistent cough after a COVID diagnosis.
Right.
Okay.
Yeah. So it sounds like you basically have to take stock of, were any of these symptoms present before the illness? If so, then this is whatever was going on before the illness. But if they're new symptoms, or if they're symptoms that have persisted since you were sick with COVID, then it could be that. It could be due to the viral infection they just had, the COVID-19 infection. But we have to think about whether or not something else could be going on that could explain it. Like, as Avi pointed out, they are on lisinopril and that's why they have a cough, or they need to be screened for, or they need a colonoscopy because they have GI symptoms and maybe something's going on in the colon that has nothing to do with the COVID-19 infection they had.
And the other thing is get an exacerbation of something they may be at risk for, just related to the inflammation with COVID. So if someone's kind of metabolic syndrome-y, is that an official term in internal
metabolic
medicine?
Syndrome. Yeah.
With the E at the end, like syndrome-y.
I think you can coin it on the podcast. That would be fine.
Yeah.
Yes, ish. And then we're seeing a lot of people develop diabetes afterwards. Just is there inflammation and stress on the pancreas related to having COVID? Some patients who, maybe borderline hypertension, and now they have hypertension that needs to be treated. So it's another kind of take and what I've seen with patients as well. Asthma that was probably controlled, and now asthma is out of control, going back to our patient.
So speaking of inflammation, given that we are still less than 2 years from the earliest recognition of this syndrome, what do we know we're recording in December 2021, what do we know about the pathophysiology or the potential pathophysiology of long COVID?
So it's a new thing, things that we're just learning about. And so we don't have definitive, this is exactly what the pathophysiology is, but we do know, of course, what's happening and the spike protein and ACE2 receptor, but we also know there is post-inflammatory cytokines. So there's inflammation in the system. And then we're still learning, there's questions about, is there viral persistence? Is there still part of the virus that is somewhere in the system, GI tract, whatever it might be, that is persistent? And so, studies still looking at that, NIH still trying to fund studies to look at that. And the other thing that we're also looking at is what is happening to the body, the individual immune response. And that is a big thing with what type of response you have. What is your cytokine storm? Is it a short-term one? Is it a long-term one? Are you creating autoantibodies? That's another major thing. We're seeing a lot of abnormal autoantibodies as well in these patients. So one of those, or all of them.
Yeah, right. And this may not be a fair question to ask, but is there something that's different about COVID? I remember early on, and I don't want to be dismissive of the post-acute stuff, but I remember reading someone saying that actually virologists were sort of initially unsurprised, and they see that you see post-acute viral stuff all the time, but because we're seeing viral infections on a scale that's kind of unprecedented happening simultaneously, we're kind of recognizing it more acutely. And I don't I wish I could find the actual source for that. But I guess the question that leads me to, is there something different about COVID that this behaves differently than other viral infections, that people are more predisposed to post-acute symptoms that happen and persist?
Yeah, so great question. And in one of my National Society meetings, we just had a point counterpoint. And I just happened to get on the side where is post-COVID just another post-viral sequela? And that, yes, it happens. Guess what? It happened with Ebola. It happened with SARS-CoV-1. It happened with MERS. It happens with, other infections that people get all the time. This is not the first time that we've had patients with sequela viral illnesses. And, I've taken care of plenty of patients with West Nile virus sequelae and with, thankfully not Ebola, but, other infections that they've had. I knew how to take care of patients with POTS and dysautonomia because I've seen them in other conditions before. So it's not like this is the newest thing ever. I just think the sheer numbers is probably where it's, bringing a lot of attention to people who had other post-viral illnesses who were suffering and didn't get as much attention as this is bringing.
And you mentioning POTS triggered one of my own neurons. I feel like I just saw a headline on one of my Journal Watch emails that there's some groups researching the component of mast cell activation.
Mm-hmm. Yeah, so for sure, that's another part of the pathophysiology is, mast cell activation. It's kind of, we're relearning about this all over again, and that there are maybe 17% of the population that has a propensity to have mast cell dysfunction. And when you put it with a disease like COVID that can stimulate it more, it's actually a lot of my patients, if I'm taking their history and I feel that some of their presentation goes with a mast cell dysregulation, then I will treat them with a mast cell protocol, and they do exceptionally well with that.
What would the illness script look like for that? Like when you're taking the history, what triggers that for you? That I do not have that readily available, but I would love to learn it from you.
Right. So anything. These patients are ones who they may have an asthma presentation, or, before they had some allergies, maybe a little asthma was controlled, and now it's out of control and everything is just a trigger for them. They have environmental triggers. They have, food triggers. Sometimes they get rashes or they get eruptions. Occasionally they may have something like eczema, and now their eczema is out of control. The other thing is some of the mast cell people, just because of sensitivities, they're the ones who are super sensitive to any medication you give them, and they can't tolerate any medication. And they have this big long list of meds that they can't tolerate. Now, you know which ones I'm talking about?
Sure.
Those ones usually have some component of, mast cell activation and dysfunction. And some of them have a lot of GI bloating, the like super, super GI bloated patient where everything is normal. Otherwise, the general normal testing, also sometimes mast cell.
And you mentioned you put them on a mast cell protocol. Is that something that's in our primary care wheelhouse, or is this like you have to send them to hematology for some infusion or rheumatology for some biologic agents?
No, it's something that I think could be in everyone's wheelhouse, and there are some papers about it. And there's labs that can be checked, and a lot of times the labs are not abnormal because patients may not be in an active flare. They may not be having an anaphylactic response to get some abnormal histamine or abnormal tryptase. And so sometimes you may not get an abnormal labs, but another part of also diagnosing it is putting them, the mast cell protocol is basically decreasing histamines around them. So whether they figure out what their triggers are and staying away from triggers, sometimes they'll do a FODMAP diet or a low histamine diet, and then putting them on H1 blockers, H2 blockers, vitamin C, vitamin D. Sometimes I'll add montelukast, and it just kind of depends on what their symptoms are. And try to be a non-sedative type of, like, not Benadryl, but hopefully Allegra or something,
Before we leave the pathophysiology, I just wanted to ask you, is it controversial? Like, are there different, like very strongly opposed schools of thought that this is more of a just sort of like a psychosocial issue, that it's not actually a biological phenomenon that's going on? I saw in the New England Journal, there was an article by Phillips and Williams that was basically saying like, we need to not marginalize these people. We need to treat them, with like utmost respect and investigate these things. And then there was another article in the journal Lung that was saying that they were thinking this is more, we should really prioritize rehab and psychological support and really not emphasize diagnostics and like advanced testing, that they didn't really think that this was a true like, pathophysiology that was disrupted here. So I don't know if those are controversial thoughts, and I'm asking from a place of, I'm not on either side. I'm just asking.
I think if you ask patients, they would say that they feel that they're being gaslit, that they feel that because of that, a lot of their testing is negative, that, people are saying you're making it up. This is something that's in your head. You need to calm down. We're all under social stresses. And I just think we probably don't have the right tests yet, because a lot of the traditional stuff is going to be fine. And that's what makes it really difficult, because, we have such wonderful tests in our wheelhouse that we love to use and rely on. Oh, we're going to get you pulmonary function tests. Oh, they're normal. Okay, you're fine then. Oh, but did they, look for a breathing pattern dysfunction, which, physical therapy can work on? Or did they use an ultrasound to look at their diaphragm and to see that their diaphragm's dysfunctional or it's thin or whatever it might be? Probably not, because that's not a traditional in our wheelhouse to use. Echoes, like, okay, let's do an EKG. Your EKG is fine, but I have palpitations and I feel so bad every time I sit up and stand up and I want to feel like I pass out. But your echo's also fine. How many times do we do tilt table testing, or know a place where they can get tilt table testing, or know how to do autonomic testing for patients, which is often the problem, not a structural cardiac thing.
What's been the model across the country? It seems like, long COVID clinics are kind of not popping up. That doesn't do it justice, but are being created. Who owns this diagnosis? Is it primary care? Is it physiatry? Is it cardiology? And who's getting involved in this work? To me, it seems that there's been a lot of interdisciplinary stakeholders.
I know it's been great that it has been interdisciplinary for sure. And I would love to say it's physiatry, but there's, a need for more physiatrists. There's only so many of us to be able to handle certain work. But the reason I love that it's physiatry is that actually our field came out, one of the things that our field came out of was the polio epidemic, because polio created so many people with new disabilities, people who needed braces, people who needed iron lungs. And this was especially in the South and Southwest where I'm from. So I like to think, all right, we're good at taking care of people in epidemics, but we're best doing it with a team approach. I can't do everything. I don't understand every type of cardiac and pulmonary test or rheumatologic abnormality that may come out, et cetera. And so I think it's best done with a team approach. And I think it's just the places that are doing it, most of it's academic centers, and they're trying to work together with who they have. If there is physical therapy, then you want therapy involved. You want infectious disease specialists, internists, pulmonologists, cardiologists, neurologists, rheumatologists, physiatrists, all the above.
Our sponsor today is Panacea Financial, the national bank for doctors by doctors. The average bank just isn't built for the healthcare community, and let's face it, they don't understand us. But at Panacea Financial, they get it because they have lived it. This bank was founded by 2 MedPeds physicians, and they are dedicated to providing solutions for the unique needs of doctors and doctors in training, including medical school loan refinance. Panacea's student loan refinance has low fixed rates that don't depend on your credit score, no maximum loan amount, and $100 per month payments while in residency or fellowship. And maybe you aren't looking to refinance your student loans, but do you know anyone who might be? Well, you can refer a friend to Panacea and they will pay you $250 for each referral. And guess what? There's no limit to how many people you can refer. So maybe this could be like another job for you. Join the growing number of doctors nationwide that expect more from their bank and have switched to Panacea Financial. Visit Panacea Financial today for more information on their student loan, refinance, and to learn about their Refer a Friend program. That's panaceafinancial.com. Panacea Financial is a division of Premise, member FDIC. We're sponsored today by Indeed. Audience, are you thinking about hiring somebody? Well, if you are, then you need Indeed, because Indeed is the hiring partner where you can attract, interview, and hire all in one place. You're guaranteed to find quality applications that are going to meet your must-have requirements, or else guess what? You don't pay, baby. Instead of spending hours on multiple job sites, combing through application, why don't you do it all in one place with one powerful hiring partner that can help you do it all? Indeed is going to partner with you through every step of the hiring process, and they have some great time-saving tools like Indeed Instant Match, assessments, and virtual interviews. And as soon as you sponsor a post, you're going to get a short list of quality candidates right away with resumes that match your post. Plus, you're only going to pay for the quality applications that meet your must-have requirements. And in medicine, we know it's been very hard to hire the people we need. So get on Indeed and find them. They're out there. Start hiring right now with a $75 sponsored job credit to upgrade your job post at Indeed.com/internalmedicine. Offer is valid through March 31st. So go to Indeed.com/internalmedicine to claim your $75 job credit before March 31st. Indeed.com/internalmedicine. Terms and conditions apply. If you need to hire, you need Indeed. I want to ask about, back to Miss Sarah S. Covey. She's 45. We didn't really give you a lot of past medical history, but she had this mild case of COVID, and now she's having all these multi-system complaints. Can you talk about, are there certain patients or certain patient factors that make someone more predisposed to these symptoms? Do we know that yet, or what you're seeing in your practice?
It seems to be women, actually. Disproportionate women in their 40s. And that's what I'm seeing in my practice, but that's what a lot of people are seeing in their practice. And it's pretty interesting that we know that, men may get the initial worst disease. So older people and men get initial worst COVID, especially hospitalized COVID. But when we look at long COVID, it is mostly women who are getting it. And, again, looking at immune responses and looking at IgG levels of their COVID antibodies afterwards. These are just, studies that are starting to be done, and that they may not have as robust response to creating the antibodies to COVID. And so that's one tie-in to it. But then the other thing that we know is what else happens to 40-year-old women? They are also the ones who get autoimmune disease more than, men or other populations. So again, there's the tie-in to what's happening to autoantibodies with long COVID.
And what about, is there a signal between the severity of the illness or whether or not they were vaccinated before they got COVID? Does any of that seem to be important in how severe or in development of this long COVID?
So definitely severity matters. And a lot of the thing is that the studies that are done are mostly done on hospitalized patients. So, you have ones like, 6 months hospitalized patients, 1 year hospitalized patients, from Wuhan. They came out first because they had the disease mostly first. And, with 70% or something still having symptoms. So those are patients who are hospitalized. And we know that patients, if you're hospitalized, you had severe disease, there is post-intensive care syndrome, PICS, that is already something we also knew about before the pandemic. And we know that hospitalized patients who were critically ill are going to have sequelae, physical, mental, and psychological afterwards. But what is the interesting part is, and then there's only a certain percentage of the patients who are hospitalized. But the other interesting part is the ones who had mild to moderate disease, who were never hospitalized. And there's still a percentage of those patients, something like 10%, even more, who are having long COVID, 30% in even one JAMA study that came out. Oh, and then, finish answering the question. Now it's all coming back. The part about vaccines. Does vaccines help? And I think at first we didn't know, but now we know they do, but it doesn't protect you completely from long COVID. So you can still get a breakthrough infection and you can still get long COVID from a breakthrough infection. Though in one study, it was 50% less chance. So, that's still wonderful chances. Still, please go get your vaccine if you're on the fence.
And while we're on the subject of vaccines, I've heard mixed anecdotes that if you've had long COVID and got vaccinated, it got better, but then there's the converse might be true as well. Or is there a signal about effect of vaccination after you've manifested long COVID?
Right. So I think if you're looking at both studies that were done by the patients who were affected by it the most, that in the mid 50s% feel that they feel better after getting a vaccine. And there are maybe then the next largest percentage, 30 plus 40% feel probably the same. And then there is a small percentage of patients who then get worse after the vaccine. So I don't know who's going to be who.
Yeah. So you're kind of rolling the dice, but overall the numbers favor, you'd feel at least the same, maybe better. Yes. I mean, if you're in the midst of long COVID, but
if you're in the midst of long COVID, because the other thing is, if you get COVID, you can get COVID again, especially if you're not vaccinated. They make the lowest level of, when we look at antibodies, you've had COVID alone, lowest antibodies, and then vaccinated has the next highest antibodies. And then if you have COVID plus vaccinated, then you're like the super antibody person. And
right.
So those are the best ones. Well, not that I'm telling people to go get
don't get COVID on purpose. Don't go to a
don't get COVID on purpose.
If
don't
you
go
had
to a
COVID,
party.
get vaccinated.
Right.
There
but
we
if you've
go.
had COVID, go get vaccinated and have like super immunity. Right.
So given what we know about, sorry to cut you off, Matt. Given what we know about misogyny in medicine and the challenges of women sometimes getting a diagnosis, and you already talked about gaslighting or patients with long COVID feeling like they're experiencing gaslighting, is that the women predominance? Is that setting us up for frustration with getting people diagnoses or treatment?
Yeah, it's that whole, you're hysterical, it's all in your head, you need to sleep, you're probably stressed. So a lot of women get that in general, but then, there's other biases as well. So, I have some patients that may be obese, and I've had, they will say, well, the doctor just says it's because I'm overweight and I just need to lose weight. But before, I was always this weight and I could walk, I could work, I could go 3 up flights of stairs. But now that I've had COVID, I can't. And so it's not, again, it's part of our, fat bias that we have, and along with our sometimes misogynistic views. And so unfortunately, this is something that a diagnosis that brings it out. And these people want to be heard, and they're being told, you're stressed, it's anxiety, it's depression. And I say, you know what? If I had this disease that no one understood and I'm having all these weird symptoms that no one can explain, I may develop anxiety. I may develop PTSD. And guess what? Neuroinflammation causes psychiatric diseases like depression and anxiety. And PTSD goes with autonomic dysfunction because it's part of having like an increased sympathetic response as well. And we've seen that in other disease states or in, people who have come back from wars and such.
So Miss Sarah Covey, it's fortunate there's a long COVID clinic near her house. She gets referred in. Feels like she's being taken seriously. It sounds like we talked about POTS. We talked about autonomic instability. What would you do for her if she's coming to you with these post-COVID symptoms? Like what testing, what management?
So again, if you're working with a multidisciplinary team, wonderful. You should still, anyone who has cardiovascular symptoms, there are guidelines on what should be done for these patients, including, often screening with troponin, getting an EKG. Some of them may need an echo. Okay, great. A lot of these patients, that's normal. And then you have to look at ones who may have POT symptoms. So I really, it's really easy to do. Maybe we don't have formal tilt table testing, but even if I'm seeing someone, I can check orthostatic vitals and what's happening when you're getting orthostatic vitals. I can do even just you're sitting down. What's your heart rate? It's 80. I have them stand up. They wait for 5 minutes. This is like a poor man's tilt table test. Their heart rate goes to 130. Oh, guess what? That's pretty much a diagnosis of of POTS, or they're meeting the criteria. If it goes up over 30 once they're up for, 5 minutes. And so then I can start saying, all right, now what do we do to treat this condition? And then it's, again, a lot of education on what exacerbates POTS. Things like standing for a long time. Okay, well, what can we do for that? Compression stockings, abdominal binders, really, really important, more than just the compression stockings alone. You're going to want to have them, not get overheated. Usually they do better in the cool. You're going to want to tell them to eat small meals throughout the day, not just, a few big meals, because the big meals will just have all their blood go into their GI tract, and then they're going to want to pass out instead of, so small meals throughout the day. Occasionally, patients will need to hydrate. So some hopefully won't get to the point where some I've had to give IV fluids, but for the most part, they can hydrate themselves with just, keep a water bottle, drink 2 to 3 liters a day, don't dehydrate yourself. Then there's medications we can use as well, which would be, some of the beta blockers. And then you have to be careful what selective versus non-cardiac selective, because if they have a shortness of breath and then you give them propranolol, they might get more short of breath. And so you might have to do something more cardiac selective for them. And then some might need midodrine if they're passing out when they're standing up. And it also depends on what other, some patients may feel that they have tinnitus or internal vibrations or numbness and tingling, and understanding that that's all autonomic as well. And so kind of telling, even if you can tell patients like, oh, guess what? That's related to your POTS. Or sometimes people with POTS have small fiber neuropathies. And so that's the kind of weird numbness and tingling and burning that you're feeling that, we're not able to diagnose on regular electrodiagnostic testing. Like EMGs look at only large fiber nerves, not small fiber nerves. And then that helps some people feel better.
Can I ask about a specific dose of some of the meds you mentioned, like beta blockers, midodrine? How do you start those at the low dose and then just kind of slowly go up? And then for the neuropathy, are you prescribing any medications for that?
Yeah, you can, but sometimes they're not going to be you can do gabapentin, you can do pregabalin, and it just depends how they help. Some they may get some benefit from, some may not get benefit from it. Mestinon is something that we occasionally also will use in POTS patients, and it has helped some of my patients, especially ones that have that internal vibration feeling.
And that's pyridostigmine for?
Yes, pyridostigmine that you usually use in, myasthenia gravis. And
wow. Paul,
when you say you usually
new
use
territory. This is very new territory.
No, all the time.
There's no usual for me and Paul in this one. I mean,
speak for yourself. Hand out like candy.
Paul has a POTS clinic every Thursday afternoon. So this was a lot of stuff. So you said compression stockings. We're familiar with that. You said maybe abdominal binders. Keeping hydrated, beta blockers, metoprolol, cardioselective beta blockers. We're familiar with that. The abdominal binder, this is just, they get this from
buy it on Amazon.
Buy it on Amazon. Okay.
Yeah. Buy it on Amazon.
All right. Well, that is quite a regimen. And I imagine just telling them that some of this stuff is normal and giving a name to what they're experiencing is probably some of the therapy, I would imagine.
Yes. And that's one thing that these clinic visits take time, because it's a lot of education. It's a lot of explaining inflammation and post-COVID and what's happening. It's validating their symptoms. They want to know that other people are having the same types of symptoms they are, which they are, and that we can try to control things as much as possible.
Yeah.
And is there any role for like cardiac rehab? Or I feel like I've heard things about the role of physical therapy in long COVID clinics and endurance training, structured exercise training.
So to tie back into occasionally these patients who have post-COVID and POTS, there's a phenotype of them who will look very much like chronic fatigue syndrome and ME. And in those patients, you actually have to they have such significant post-exertional malaise. So it's important that you screen patients for PEM and that's the case where, They try to do an activity or they feel good and they feel like they can do something. And then afterwards or the next day, they're knocked out. They may say, I tried to go for a walk because I felt good. And then I spent 2 days in bed and I couldn't get out of bed. Because those are the patients you cannot.
Post-exertional malaise. Is that what
Yes.
Okay.
I just heard about this. I just read a whole thing about this. My brain is going like, oh my gosh, like I have an illness script for this.
Yes. And so for them, it's really a lot of pacing. You can't give them a full, traditional therapy exercise like you would for someone who is in the hospital and maybe had, heart failure and needs cardiac rehab. No, these patients need really individualized education about prioritizing what they need to do, energy conservation, pacing themselves. And sometimes therapy can educate them on that.
Monica, I had come across when I was prepping a Royal College of Occupational Therapists. They had a conserving energy web, post. And it was like very much, it's like pace, plan, prioritize, and exactly the stuff you're talking about. So we can put that link in the show notes because I think it would be helpful for people to give to their patients, like when they're seeing them in clinic, like,
right.
Some of this is common. And mentioning the chronic fatigue, myalgic encephalomyelitis, or is it myalgic encephalitis, chronic fatigue syndrome? The diagnostic criteria say like 6 months of symptoms, and couldn't just having COVID put you at risk for developing that? Don't we think? I thought maybe just like any major illness could then could just develop that afterwards, right?
Exactly. So it's another, like we had talked about early, post-viral, people who got CFS, ME, maybe not all the time, but, mono could cause it. And then some other just type of illnesses. And now we're seeing it in COVID and post-COVID. And so it's really important with those patients that the P's, like,
right,
not overdoing it. And
to round out the diagnosis for that. So it's like more than 6 months of symptoms. And then they have this post-exertional malaise, fatigue. The fatigue's very prominent, and then they have cognitive symptoms. Can you?
They have so the three main things. So it's the significant fatigue, the post-exertional malaise, and then the third one is that the sleep is bad. They're just insomnia. They can't sleep, non-restorative sleep, and then the extra two things. It's either cognitive and or the autonomic dysfunction.
Okay.
Which a lot of these patients have. And I'm also going to put a plug in so in the PM&R journal, we put together a consensus statement for fatigue with a lot of the people from post-COVID clinics around the country, including multidisciplinary as well. So we have a lot of more recommendations related to fatigue.
Well, thank you for sharing that. We will definitely put that in the show notes. Well, I feel like we've learned a lot about the care needed for our first case at Kashlak. I'm going to pivot us to the second case, and hopefully we'll talk about other facets of long COVID. So our second patient at Kashlak today is Mr. Pascal Bfog, who's a 60-year-old man who was diagnosed with COVID in summer 2021, so sort of probably during the Delta surge. His symptoms were mild. He didn't need the ER or PCP. So mild nasal congestion, had subtle loss of smell and taste for about 3 days. And actually, his symptoms in retrospect were so mild that he didn't get tested at the time, but got tested and confirmed the diagnosis when his spouse also developed symptoms. And sadly, she had a very severe course, was in the ICU for a couple of months, including intubation and ECMO, before passing away in October. So he's understandably had a really tough 6 months, mourning his wife, not sleeping well. It feels like he has brain fog. Initially, he just thought it was depression and being sleep deprived. But he's also stopped drinking coffee because he can't handle the taste. He's wondering if that's contributing to his energy levels. But now he's also worried he's handling her estate. He's back to work as an accountant, and he just doesn't feel as mentally sharp. He's actually getting very nervous, very anxious that he might be developing dementia. And he's like, I just can't handle another thing this year. Like, what else is going to happen to me? And he's heard about the local long COVID clinic at Kashlak through a local internet support group. And he's really optimistic that he might get some answers and help.
Mm-hmm.
So let's talk about the neurocognitive or neuropsychiatric manifestations of long COVID. You did a little bit of setup with neuroinflammation and psychiatric manifestations.
Right. So definitely there are some of the top complaints are neurologically related. So, headache, up to almost 40-ish% of patients who might have headache afterwards. Attentional disorder, in another probably quarter of the patients. You have memory loss in 15 to 20% of the patients. The other big thing I will hear from patients, if you kind of probe about what their brain fog is exactly and what they're having cognitively, is an anomia. So they really have a hard time finding words, simple words that they knew before. If you ask about them, it's almost universal that you'll hear that, along with the attentional, and then just some memory farts with things that they should normally remember. I walk into a room, what was I going to do? And is that part of the memory or is that part of the attention? And if you think, like, even loss of smell and taste is a neurologic finding as well, that's our cranial nerves. And that is also a good, up to 15, 20% of patients that have that too. And so again, it goes with, as we're learning, neuroinflammation. Definitely there is disruption of the blood-brain barrier. So I tell people, you have inflammation through your system, your post-inflammatory cytokines, there can be some, the blood-brain barrier can get leaky. Do these usually inflammatory cells get past that, which we're not used to having? There's a question if, they're looking at, postmortem with patients who pass, is there COVID in the brain? Is COVID just going to be hanging out in the brain like in other diseases where, one day is it going to be like, ta-da, hopefully not. Is the inflammation part of causing inflammaging and going to be aging people a little bit faster? This is the scary part of the talk, right?
Yeah,
and this is not
scary.
It is scary.
I don't want to hear the word inflammaging. That is not. I do not. That's upsetting.
Never happened, actually.
Yeah, no, right. 2 thumbs down.
2 thumbs down to inflammaging, but yeah. So part of what I also tell people is, here we have this inflammation. What is everything you can do to, I don't have a magic like whole body plasmapheresis where I can, change your milieu and change all your cells and take your spleen out or whatever it might be and give you a new thymus or something. So, what can they do naturally to decrease inflammation in their system? And that is just, I think any doctor can tell a patient to do that. Eat healthy, eat the right kind of diet, control your other disease states that you have, kind of thing.
Yeah. Paul, does it ever, it's like, it's kind of morbidly funny that for just a lot of what we do in primary care, we're like, you got to take better care of yourself. And like, there's not like one silver bullet for like all these things. I mean, time is also, there's the great South Park episode where they joke about, he needs a time transplant. Maybe if we had more time. I think that does a lot of the work for us, because we don't have a silver bullet for these things.
It's the Voltaire quote all over again, is that medicine being the art of distracting the patient while they heal themselves. Like, yeah, we can put on a dog and pony show, but a lot of it is just sort of the passage of time and people getting better, ideally.
But Monica, I think what you're saying too is like, you want to do everything you can so that this isn't more prolonged than it's going to be, because right now we don't have necessarily have a specific thing we can do for this.
Right. We just have to optimize everything we do have. If they're not sleeping, we need them to sleep. If they're snoring all night, we need to get them a sleep study so that they can get a CPAP and they can sleep. Are they just eating junk because they are too tired to cook? Then, what can we do to ensure that they have access to better quality food that they're putting in their body? And hurry up and wait.
So are there analogies to be drawn, like based on right here, right now, what we know about the pathophysiology? Are there analogies to be drawn to like post-ICU syndrome or post-concussive syndrome or other like post-stroke syndromes? In our pre-recording, you dropped an interesting pearl that I promised I would prompt about cranial nerve 1 involvement with traumatic brain injuries.
Mm-hmm. Right. So part of the reason why I got behind this was that, I'm a brain injury doctor, and my job before was taking care of these patients who had brain fog, memory issues, loss of smell and taste, because guess what? Cranial nerve is the most common nerve that's injured after a traumatic brain injury. though, in our notes, cranial nerves 2 through 12 intact, we never check one, but that's actually really affected in traumatic brain injury as it is in patients with COVID. And so I knew before what things you could do to treat patients who had dysfunction with, loss of their smell and their taste. And so I thought it was very much like a post-concussive patient. And so we use, what are some of the things that we do there? And some of it is also a multidisciplinary approach. Like, do they need therapy because they're dizzy and they need vestibular rehab? Do they need speech therapy to work on some memory techniques to make up with what they lost? Do I need to treat their headaches because they have headaches? Yes, I will, aggressively treat their headaches. Do I need to make sure that they sleep because they can't sleep? Do they have concomitant psychosocial issues and psychiatric issues that need to be treated? Yes, I can do all of that.
So it sounds like a lot of this, I think most primary care doctors are pretty comfortable giving medicine to work, treating headaches or working up headaches. How often for things like brain fog or the memory or the attention problems, who should we be sending people to help with those things? Is that an occupational therapist that you would recommend, or are you recommending I guess we could send them to if we're lucky enough to have one of these long COVID clinics in our area, probably that would all be included there.
Right. So sometimes, speech therapy. So speech therapy isn't just about swallow or your ability to say words, but also just, the techniques for people to help them, remember things, or also to kind of do a little bit more assessment. Occasionally, I have a neuropsychologist that's in my clinic, and I can refer for someone who needs maybe more testing or needs some accommodations for their work, or we may worry about someone having to be put on disability, especially depending on what the job was that they did before. And so again, using the team that I have.
And any practical tips for patients as far as just like the memory or the brain fog before, there may be a delay. If they see us in clinic, anything we can start tell them in that visit that they might do just to help mitigate some of what they're experiencing?
Mm-hmm. So one good thing that's a reminder is that, cognitive activity is more fatiguing than physical activity. I said our brain is the most metabolic organ in our body. That's why, why after a code you want to, do CPR right away so they get blood to their brain, right? And because of that, they have to also realize that, they may have been off for physical reasons, and then someone goes back to work and they fail at work because now they have to start thinking and using their brain and processing and using their frontal lobes and doing, multiple things at once. And then that's when they really get post-exertional malaise and can't get back to work. And so sometimes you have to, for someone to be really successful, I may have to have them do a graduated return to work program, almost like you would do for someone after a concussion where, okay, you can't just go right back and play. You have to first do this program over a week until they clear you from the protocol. The same thing, if someone's going back to work, well, only go 3 times a week and then see how you do. And then, okay, then now you did that for a couple weeks and go back more. And so that's one thing. And then the other thing is, again, optimizing brain health, like we talked about. But again, if neurologic evaluation, if there is something else that's off, then they may need more imaging, or they may need, to see neurologist or a brain injury physiatrist. So,
that's fascinating. This so reminds me of high-powered professionals I know who've had really rocky course, a really frustrating course after a concussion. Physically they felt fine, but they're just so frustrated that they don't feel like themselves, or they can't work the same 10-hour day that they used to. I feel like I've read some really fascinating things. Again, getting back to the interdisciplinary team, the role of ENT physicians in recovering smell and taste. There was an article, and I can put the link in the show notes, about opera singers helping with elements of long COVID and post-COVID recovery. I think there was something that I see. I don't know if I saw this. Maybe I'm making this up. Like sommeliers doing smell training.
Sign me up. Right.
Yeah,
So that's one thing that
not taste training, just smell training. That seems like a ripoff if a sommelier is just like letting you smell the wine but not taste it. So hopefully
exactly.
it was both.
Right.
Well, can we talk about taste and smell? I'd be curious if you have any tips, Monica, for the patient that's suffering from loss of taste and smell, and let's say it's been months. I've met some patients personally and in clinic that have really lost taste and smell for months, and they're starting to be worried it will never come back.
Right. And we don't know, and don't tell someone like it's never going to come back, because they don't like to hear that either. And don't tell them it's better if you started smell training in the first 6 weeks, though that's true. We don't want, we still want to encourage them to do it. So, whenever you see them, you can, there's different websites, there's different little kits, and, they can start working on smell training. The other thing is sometimes also, intranasal steroids will help with that as well. And so I will occasionally give patients intranasal, do intranasal steroids while you're doing smell training. And then the other thing is, if their taste is off, and sometimes they'll go through this like no taste to a little bit of taste to then it's dysgeusia, where it's like it tastes bad, where, food that usually was appetizing now tastes like, they'll say something, it tastes like sewage. Well, I hope you don't know what sewage tastes like, but, is there a way that they figure out how they can flavor it so that way it may be more appetizing to them? And then the other thing is just watching their weight. If food tastes bad or they lose their taste and then they don't eat, then that might put someone at risk for malnutrition.
I wanted to ask for a friend of mine, maybe let's say his name is Paul. He's not exactly sure what smell training is. So could you just, for his benefit, could you tell us what that might look like in practice?
Yeah. So it looks like you usually have someone get 4 types of different smells, or it's usually essential oils, and you practice for 15 or 30 seconds in each nostril, smelling the scent and then making the mental imagery too with it. So if it's a lemon smell, then you should be trying to smell it and making in your head a picture of a lemon, and that's supposed to help. Then you go through your next smell, and you do this a couple times a day for a set period of time.
So you obviously have to be familiar with these smells in order to do the mental imagery of what it's going to smell like. If you've never smelled like I don't know,
rosemary or seen one, then you may not.
Right. Yeah, I might be in trouble. I think I had lemons and stuff, but if people are like naming flowers and what lilac smells like, right? I'll be like, I don't know. Yeah, Avi, I don't know what truffles smell like. I
know what they taste like. Thank goodness for, can I say, make a plug for Trader Joe's, like truffle powder? I don't know.
Yeah, of course. Of course. Yeah. Okay. So that seems that seems like something, I guess, even if they're waiting to get in to see an otolaryngologist or someone else that's going to help them with this, they could even try to start doing something like that at home on their own, taking the intranasal steroids. And then you said, of course, we have to watch their weight. Another fun resource that I found that people can give to patients, and maybe Monica, you have another UK website, and this was fifthsense.org, and they had safety advice. I was telling Paul about this ahead of time. They had safety advice and also some hygiene advice. They're like, yeah, like have a friend or someone you trust that can smell food for you, but also they can smell you and tell you if you smell, because you can't smell yourself, which I thought that was just delightful.
They have an absent website, absent.org, that also has kind of instructions on smell training. But it is, you also have to educate people. If you can't smell, but I live in Texas, where sometimes there's refineries nearby, and you work in a refinery, well, then guess what? You better make sure that there are alarms working, and in your home that your fire alarms are working. And just to be safe, your carbon monoxide alarm is working, even though you can't smell carbon monoxide.
Yeah. Yeah, I thought those were all just really like practical and fascinating things, and things that, as someone who's privileged enough to still be able to smell things right now, I never would think about those things. So you tell people what does it sound like when you counsel a patient about that? Like when you tell them about the potential prognosis, like if someone's like, doctor, I'm worried I'm never going to smell or taste anything again. How do you, put them at ease?
So it's just we don't know. These are some of the things that you can try if you're having altered taste or smell. And, I'll leave you the website and explain to them about what smell training is and what they can do to be safe, and try to figure out, what flavors they have, kind of educate them a little bit about, how can we make food appetizing to you so that you are eating something. And just kind of reassurance and education on what we know. There are some studies where they're actually trying to see if ginkgo biloba might help with smell come back. There's some clinicaltrials.gov. So some patients may try that supplement. We don't know what the outcome is on that.
Okay.
So something I wanted to ask about, we had touched on, I think, mood and PTSD as maybe a component of the post-acute COVID syndrome. I also think it has to be hard to tease out from the fact that we've all lived through what is an ongoing national tragedy to some extent. We've lost people that we've loved, or we've had patients who've loved folks that they love. So there's a lot of collective trauma that's happening right now, I guess is what I'm saying. And I think, as Matt alluded to, a lot of primary care doctors are comfortable dealing with that to some extent. But I wonder if you couldn't help me out in terms of, I think we mentioned support groups briefly, but if you could just talk us through some of the resources available to our patients for emotional support and sort of peer support as they're also in this recovery period.
Right. So thank you, primary care physicians, who are comfortable in doing so many things and taking care of our patients. And you're right. And some of it is a sequela of long COVID, and some of it is a sequela of living in 2020 and 2021 and now 2022, right?
Oh, don't drag 2022 into this. I still have hope for it.
Okay, right.
This will air in 2022, Paul.
And so I think screening patients, we screen all our patients with, PHQ-2s or PHQ-9s, and just kind of looking for any red flags or symptoms, and then being able to ask certain questions or make referrals to psychology. There is an app called COVID Coach, and that app is a free app that's made by the VA and the DoD. They have a lot of resources for patients with COVID related to mental health, some relaxation, some breathing, just different types of helpful evidence-based things that they've used before in veterans and in military. And then there is social media groups that some of these patients with long COVID have found as being good supports for them. And, they have different ones all through, Facebook groups and also through the web. And so certainly I will encourage some patients to get in those. Sometimes patients will say it's really depressing getting on those. So then maybe they need to find their own local support group, or they need a referral to a counselor, behavioral health specialist, or a psychiatrist in some cases.
I feel like I've also heard about patients for all the potential gaslighting and feeling like they're not being taken seriously, that there is also a very strong component of the patient voice, including in the creation and implementation of some of the long COVID clinics that have gotten themselves off the ground.
As well as the research. So they have like patient-led collaborative, and these are people who themselves had long COVID, who were otherwise in, careers where they maybe knew stats or did research, and, then they're getting the information firsthand from all these survivors. And they're some of the ones that have come up with a lot of good research on long COVID. So it's wonderful that, the patients have been able to come together and really push the agenda for us. And I think, we have more and more of, okay, we have an idea. We know what the symptoms are now. Now we need to figure out the scientific pathophysiology and treatments. We really need treatments.
And speaking of the patients suffering from this, there's going to be patients asking for us to fill out forms to help with short-term disability or longer-term disability. What's the status of that? Do you have any tips? How's that being handled right now?
So I do it. It's probably the second most important thing you can do. First is, validation and helping them get treatments. And then the second thing is, what is the support for either work accommodations or disability? And, knowing you have to keep things in mind that patients need time to recover, that they can get relapses. So sometimes for FMLA, you may have to say that this could be a chronic condition and they may have to have relapses and take time off from work. Again, like I had said, what's going to push them to, have a relapse is going to be, again, working, stress, pushing themselves too much, the post-exertional malaise. So, again, like I had said about the really graduated return to work, I had one patient where she said, well, I started doing part-time at home, and then I could, build that up to going to the office a couple times. And guess what else I did for her? I gave her a handicap placard. So that way she wouldn't have to walk, a whole length of the parking lot. And by the time she got into work, she was too exhausted to do work. And I know sometimes we want to see someone being really physically disabled before giving them a handicap placard. But for patients like this, we, really need to know energy conservation. And that is, taking fewer steps so that they can get into office and work. Of course, this ties back into, social determinants of health. Some people don't have work that they can do from home. Some people have to have a work where they're standing on their feet all day and they have autonomic dysfunction. And so those patients maybe need more long-term disability accommodations.
So I think we're going to have to go to take-home points here. We've talked through a ton of stuff today. We started off talking about more of the cardiovascular fatigue symptoms, then we started talking about the neurocognitive symptoms and ended up talking about disability. But out of all that great stuff that we talked about, can you give us like 2 or 3 favorite take-home points that you really want to make sure the audience remembers from this talk?
Believe patients. So, really kind of make sure that you're providing support, that you're, telling them that this is a condition, this is something other patients have, that you believe that they're suffering, don't blow them off. So that goes a long way. Providing the education and, trying to do what you can. So not just like, there's nothing we can do, give it a year, we'll see what happens. But, using your interdisciplinary team to try to do as much as you can for the patient, even if that means giving them some work accommodations or giving them, a referral to a support group or to a behavioral health counselor or to physical therapy.
Okay. Well, we will fade this to the outro. Thank you so much for all your great teaching.
Thank you so much.
Yeah, thanks. I was happy to be here. It's a very famous podcast. So.
You're certainly exaggerating, but we appreciate it. Thank you.
Like the most niche way possible, but yeah, that's nice. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox. Plus, twice each month, you'll get our new Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to providing you with high-value, practice-changing knowledge, and we want your feedback, so please subscribe, rate, and review the show on Apple Podcasts, or send us an email to thecurbsiders@gmail.com. A reminder that this and most episodes are available for free CME for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. Wanted to give a special thanks to our producer for this episode, Dr. Avital Oglasser, and to our whole team. Beth Garbitelli is our executive producer and runs our Twitter. Maddie Mad Dog Morgan is on Instagram. Tima Karganov does the website. Stuart Brigham composed our theme music. And Claire Morgan of Notterly edits our audio. And finally, Chris the Chew Man Chew is on Facebook. So with all that, until next time, I've been Dr. Matthew Frank Watto.
And I've been Dr. Avital Yehudit Oglasser.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.